Hello and welcome to another installment of our endodontic videos. Today we're going to be talking about periapical pathology. In oral pathology, there are entire textbooks dedicated to lesions of the jaws, but for this video I wanted to briefly review the three most common periapical lesions. These three are categorized as lesions of endodontic origin since they are the sequela to pulpopathosis. The first and most common is the periapical granuloma. Perhaps representing one of the most painful lesions is the periapical abscess. Finally is the periapical cyst, which can be further broken down into the true cyst, which is independent of the root canal, and the pocket cyst, which communicates with the canal of the root. It's important to note that unless serial sectioning is performed, it's difficult to appreciate the true nature of these lesions, even on a histologic level. In probably the most frequently referenced study by Nair in 1996, the relative percentages from biopsies were described. 50% of the biopsies were determined to be periapical granulomas, while 35% were periapical abscesses. While 15% of the biopsies were periapical cysts, he further broke them down, with 8% being true cysts and 7% being pocket cysts. In our review of periapical granulomas, we have an opportunity to discuss the classic zones of Fish. In Fish's paper, he describes microorganisms finding safety within empty habersion canals. In the context of a periapical granuloma, however, the root canal provides this hideout as the zone of infection where host immune defenses cannot reach. This zone includes some microorganisms, and on its periphery would also include the neutrophils. Outside of the zone of infection, we find the zone of contamination, which includes toxic breakdown products of the microorganisms that have been destroyed by the neutrophils. Also present are endotoxins or exotoxins, which are also often those breakdown products. We also have what Fish refers to as round cells, which we more commonly know today as T lymphocytes. In the zone of irritation, we still have the irritants and breakdown products, but in addition we have the histiocytes, which we know as macrophages, and the osteoclasts. Outside the zone of irritation, we have a zone of stimulation. This is where we have fibroblasts and osteoblasts laying down new bone. A periapical abscess is a collection of purulence. It is one of the few lesions where extraradicular infection is routinely present, and it represents an intense immune response that's mounted against the microorganisms. The spoils of this fierce battle form the contents which, as they build up, increase the pressure and the pain for the patient. Bacterial enzymes are also present from the microorganisms, and they have the capability to digest host barriers. Without eradication of the source of infection, further spread can even be life-threatening. Periapical cysts are fluid-filled cavities with epithelial lining. In order to understand the origin of these epithelial cells in the periapical region, we need to recall that at the end of tooth development, as Hertwig's epithelial root sheath disintegrates, small bundles of epithelial cells remain, called the epithelial cell rest of Malassez. While we tend to think of these epithelial cell bundles as isolated clumps, in a three-dimensional reality, they form more of a fishnet appearance. In their normal state, they are quiescent. This quiescence is normally demonstrated by their high nuclear to cytoplasmic ratio and their small amounts of RNA. While the first step of cyst formation includes this activation of the epithelial cell rest of Malassez, the second step is a little bit more controversial, and there are various theories to explain the formation of these cysts. The first that we'll be discussing is the cavitational theory. In the cavitational theory, the epithelial cell rests proliferate and form large clumps. Within this theory, the center of the clump is described as being far enough away from a nutrient source that it leads to cell death, forming the cyst cavity. While in the past, osmotic imbalance was attributed as the cause of cyst expansion, newer research suggests molecular signaling leads to this expansion. The next theory is very similar, introduced by Torbinejad. The immunologic theory describes a similar proliferation of these epithelial cell rests. Instead of the central cells dying from a lack of nutrients, Torbinejad suggested that immunologic factors cause the apoptosis and cell death of those central to the clump. Once again, molecular signaling leads to expansion. The abscess theory describes epithelial cells and their inherent ability to line connective tissue. So in this theory, the cavity is formed and epithelial cells proliferate along the connective tissue surface. And finally, the fusion theory. The fusion theory suggests that the epithelial cell rests proliferate, strangulating the connective tissue found in the middle. Once this connective tissue dies, then the cyst forms and once again expands. In addition to the periapical lesions of endodontic origin, your reading included important information highlighting the less common but often more serious diagnoses that should always be included in our differential. Not only should you review your imaging for these possible findings, you should also be sure to seek out the gold standard of histological examination when appropriate. Also in your literature, be sure to review the position of the AAE on Nico lesions so you know what this cavitat readout is all about. Thanks again for your attention today. As you get ready for the seminar, be sure to understand the rationale and evidence behind all of these theories that we discussed. Once again, happy studying.